Okay, so in our first presentation, we were talking about the glomerulus, how it fed and drained by arterioles, the afferent arteriole being larger than the efferent to help generate pressure, that this whole structure of the glomerulus is specialized for filtration, and that the high pressure caused by this afferent arteriole as opposed to the efferent arteriole is what forces fluids through the glomerulus. So let's take a look again just at the image, and you can see the Bowman's capsule, which becomes part of the proximal convoluted tubule, which collects fluid which comes from the glomerulus, which is fed by the afferent arteriole, which is bigger in diameter than the efferent to allow sufficient pressure. So now, we talked about peritubular capillary beds, and these arise around the efferent arteriole of the glomerulus, which has a lower plasma content, and it absorbs a lot of the fluid by osmosis. These are normal, not leaky, low-pressure capillaries. They are adapted for absorption instead of filtration, and they cling very closely to the renal tubule to resorb or reclaim some substances from the collecting tubules. Now, let's take a look here at the collecting duct. It receives urine from many different nephrons and runs through the medullary pyramids, delivers urine into the calyces and the renal pelvis. Microanatomy questions then that we would ask: what is the functional unit of the kidney? And there, the answer that we're looking for is the nephron. What is the knot of capillaries called? That's the glomerulus. What is the cup located? It is the Bowman's capsule, and it is located as part of the proximal end of the renal tubule. And what are the sections of the tubule? We have the proximal convoluted tubule, the distal convoluted tubule, and in between the loop of Henle. So let's talk now about normal characteristics of urine. Solutes that are not normally found in urine are glucose, which we do see for people who have diabetes. It is protein, which will generally be indicative of some sort of kidney disease. Blood, which we can see when there is some damage to the nephrons or other part of the urinary tract. Hemoglobin, which we can see if there is a hemolytic disorder of some sort. Bacteria, if there's an infection. Ketones for high protein diet, fat metabolism. So if you are eating a high protein diet, you may have ketones in your bloodstream, and bile, and also pus or white blood cells. Now, the normal nature of urine is that it is sort of between a clear to a yellowish color. It is slightly aromatic, that is, it has a smell to it, and relatively translucent. Now let's take a look at some of the conditions here. You can have a lot of glucose in your urine for non-pathological reasons if you ate a really sweet meal or something. You know, if I had some sheet cake with ice cream on it and chocolate drizzle of chocolate sauce, I would probably end up having some sugar in my urine, but that would be a temporary state. It's not pathological. Pathologically, we see this in diabetes. Now, proteins, and this is called proteinuria, what we see there, non-pathological, you could have physical exertion. So someone who is doing a lot of physical exercise might end up with protein in their urine. We also see it in pregnancy. Now, pathologically, what you have could be glomerular nephritis or high blood pressure. Pus in the urine, that is never normal. There's not a possible normal condition for that. but you've got some sort of urinary tract infection as a result. Red blood cells, called hematuria, bleeding in the urinary tract, usually due to some trauma. It could be indicative that you've just passed a kidney stone or have some sort of infection of the tract. Hemoglobin, you can get that from transfusion reactions and hemolytic anemias. Sickle cell anemia, for instance, may end up with hemoglobin in the bloodstream. And bile pigment, which is an indicator of liver disease, since the liver typically is able to remove any bilirubin that may exist in the bloodstream. Now, again, another view again of the structure of the nephron. Now, urine formation, which occurs through this entire nephron, consists of three activities. It involves filtration, which occurs at the glomerulus. We've already talked about that. It then involves reabsorption, and most of the reabsorption is in the proximal convoluted tubule, reabsorbing materials that we don't want to get rid of. And then tubular secretion is where we will add stuff to the urine, just extra things that we really don't want to have in the bloodstream. So, urine formation, again, we've got filtration occurring, and that's where water and solutes smaller than proteins are forced through the capillary walls. Tubular reabsorption, we reabsorb most of the water. You know, we have about 190 liters of water that we filter a day. We reabsorb all but about 2% of that. So maybe 1.5 liters is what we end up peeing out, and the rest of it gets reabsorbed. Glucose, again, we don't see glucose in urine. Amino acids and ions that get transferred out of the filtrate into the tubules, we collect those back. So sodium, potassium, things like that. Now, tubular secretion, we can get rid of hydrogen ions. That's acid, basically. Potassium ions, creatinine, and other drugs. Drugs are removed from the peritubular blood and secreted into tubule cells into the filtrate. Now, filtration is a non-selective process. Anything that can get through those filtration slits is going to. So water and solutes smaller than proteins go through there, and that includes glucose, sodium, potassium, calcium, all things that our body needs to preserve. So this non-selective process basically requires then that we do an active process to gain all of that back. Proteins and blood cells, again, are normally too large to get through into the filtrate. Peritubular capillaries reabsorb most useful substances. As I said before, about 98 to 99% of the water that we lose in filtration gets reabsorbed. Glucose, nearly 100% of that is reabsorbed. Generally, it is 100% of that, but sometimes it can spill over into the urine if it has a high level in the bloodstream. Typically, blood sugar levels run between 80 and 100 milligrams per deciliter. When it gets into the 300 plus range, that's when we start seeing it spilling over into the urine. Amino acids, these make proteins, and these are normally reabsorbed. And ions, depending on what the body needs, it may let go of some ions because ions are involved in removal of water as well. Some reabsorption is passive, most of it is active, and most reabsorption occurs in that proximal convoluted tubule. So water reabsorption, in this case though, that is obligate reabsorption. We don't actively transport water. What we do is we transport the sodium ions, potassium ions, calcium ions, and sugar, and through the process of osmosis, the water gets drawn back into the tubules as it follows the salts and sugars. I think the thing to be aware of is that water always follows salt and sugar. Now, materials that are not reabsorbed include nitrogenous waste products, urea from protein breakdown, uric acid from nucleic acid breakdown. These are the things that give urine its slightly yellowish color and its slightly pungent smell. And also creatinine, which is associated with creatine metabolism in muscles. So creatine phosphate breakdown. So if you were to do an excessive amount of exercise, you're going to be peeing out creatinine. I shouldn't say excessive amount of exercise, but if you are working hard, you will have creatinine. Now, tubular secretion, that is basically just the reverse of reabsorption. Again, we are putting stuff that we don't want in our bloodstream into the urine to be gotten rid of. And this includes hydrogen or acid and potassium ions. It includes creatinine and toxins and drugs. Now, this is one of the reasons that urine samples are a good way to test for drugs, because the urinary system gets rid of most of the drugs or the byproducts of drug metabolism. Process is important for getting rid of substances not already in the filtrate, and materials left in the renal tubules move toward the ureter from that point. So sites of filtration, reabsorption, and secretion. This is just a graphic that shows you this. We have filtration occurring in the glomerulus. We have reabsorption occurring in the proximal convoluted tubule and a little bit in the loop of Hindley. Then we start having secretion at the latter part of the loop of Hindley and into the distal tubules. So if I were to ask you, where does this particular process occur, you should be able to name either the glomerulus, the proximal convoluted tubule, or the distal convoluted tubule. Now, all of this feeds ultimately into the collecting ducts, which are located again in the renal pyramids. The collecting ducts lead to the ureters, which are slender tubules which are attached to the kidney and to the bladder, and they are continuous with the renal pelvis. They enter the posterior aspect of the bladder. They are lined with a mucous membrane, and they have peristaltic action, which actually milks the urine toward the bladder. They are also retroperitoneal, and they function to drain urine from the renal pelvis to the urinary bladder. Now, urinary bladder, its structure, it is a very elastic organ. It's capable of stretching a lot. You can hold more than 1 liter of urine, up to 1.5 liters, in fact. And there is a muscle called the detrusor muscle, which will contract when you urinate to force urine out. It's lined with mucous membranes arranged in rugae. Those are folds similar to the stomach, which allow a lot of stretch. And this contains the transitional epithelium, which is the one epithelium that can truly stretch in all directions. In the males, the prostate gland surrounds the neck of the bladder, and this can cause some problems for males later on in life, and we'll discuss how that comes into play a little later on. But the function of the bladder is to store urine before voiding, and then it forces the fluid out once we start voiding. So here's a view of the bladder. We have the ureters that feed into the posterior part of the bladder. There is actually the internal urethral orifice, and the bladder can fill. There are a couple of sphincters that are involved in controlling whether we urinate or not. There's an internal sphincter and an external sphincter. The internal sphincter is under autonomic control. We have control over that, but we can control the external urethral sphincter. Now, urinary bladder capacity, generally, we get a signal to urinate at about 350 milliliters, which is around 11.8 ounces, which is just about the amount in a Coke can. So, if you had a 12-inch can of something, you could pretty much pee a 12-inch or a 12-ounce amount of fluid out. A moderately full bladder is about 5 inches long, and it holds about 500 milliliters of urine. So you will feel a need to go at that point. Usually we start getting a signal that we might want to go at 350, but 500 milliliters, we're going to feel a bit more urge, but we can hold up to twice that amount of urine, so almost a liter. Here's the general size and shape of the bladder. If it's empty, it's this pinkish orange area here behind the pubic bone. If it's full, it will extend up into the abdominal cavity. Now, the urethra. This is what allows the body to empty urine, and it's a narrow tube that runs from the urinary bladder to the outside. And this is actually a good place for us to stop, and we will pick up again in a later presentation.